madam. Now we have last presentation of the session by Dr. Qutsia Nawaz. She is assistant professor at CMH Lahore, and she is going to present a comparative analysis of Q-Rush versus conventional total abdominal hysterectomy.
Assalamu alaikum. Bismillahirrahmanirrahim. First of all, I would like to thank all of you for patient listening, and special thanks to Ma'am Nazli Hamid for creating this forum. My mentors, Ma'am Shazi Shakil and Ma'am Humaira Tabassum, my team at CMH Lahore, and my HOD. So, let me begin with a moment that many of us being surgeons realize in the process of doing total abdominal hysterectomy. We are midway through an abdominal hysterectomy, I would like you to imagine. The uterus is mobilized, your assistant is holding the retractors, and you enter the familiar rhythm. Clamp, cut, ligate. Clamp again, cut again, ligate again. Pedicle after pedicle, instrument after instrument. And then finally, after all, we remember, oh yes, the vault. We have to suspend the vault. At that moment, I realized something important. Sometimes in surgery, we follow the traditional approach so much that we forget to question its efficiency. This led me to a very important and simple question. Why are we doing so many repetitive steps in this surgery? What is the added value that each step to my operation? Because when we step back and observe the traditional workflow of open abdominal hysterectomy, we realize that the procedure was designed decades ago in the era where surgical efficiency was neither analyzed nor questioned the way we analyze the things today. Yet today, we know something very clearly. Every additional step in surgery means the longer operative time, more instrument handling, greater surgical fatigue, and potentially more room for surgical error. And even after all these steps, the vault support requires yet an added step, and sometimes it is remembered, sometimes it is forgotten, as is clearly mentioned in the literature. Henry Ford, the father of Ford automobile, established that the waste of time and motion is the greatest inefficiency in any system. And when we look clearly at the traditional open hysterectomy, we see a lot of inefficiency, repetitive motions without true value addition. Multiple clamps, repeated pedicle handling, assistant-dependent steps, but then there is the paradox. Even after all those work, the vault support is not always guaranteed because it is not built in the system. And the chief reason documented in the literature is the surgeon fatigue leading to forgetfulness, and the very last step leading to post-hysterectomy vault prolapse as a consequence. And that raises a question. If the nature has already given us the uterosacral and transcervical pedicles, the true suspension system, why not we integrate them directly into the vault in the hysterectomy workflow, and why do we need an added step? What if we could redesign the workflow of open hysterectomy in an approach that is simpler, faster, and anatomically smarter? The question led to the development of the technique that I'm sharing with you today. I have named it Q-Rush Hysterectomy. The mnemonic stands for Qutsia's Rapid Unified Suspension Hysterectomy Approach. The idea is extremely simple. We have to remove the non-value added steps and bring additional value to the essential surgical step. Thereby, we can minimize the timings and increase the efficiency of the surgery. So here I'll try to signify. So at the start of the surgery, we will place holding clamps on both sides of the uterus. And after that, the clamps will have no further role until we reach the transcervical ligament. The holding clamps will be used mainly for maneuverability, and after that we will open the vesico-uterine pouch from the midline and extend the vesico-uterine pouch on either side up to the round ligaments. Thereafter, we take the round ligament along with tube-ovarian or infundipelvic ligament on each side together on both sides, and this will save us an additional 5 minutes. And we will use the suture to directly ligate the pedicles together and cut. So the step of clamping will be omitted while securing the pedicles. Thereafter, the first two pedicles have been taken. We will directly ligate the uterine artery by using OSHA clamps, the blunt forceps. And after we have ligated the uterine artery securely, we will transect it in the supportive tissue on the medial to the uterine artery so that the artery can be lateralized away from the operative field. And after that, we will place the holding clamp like this in inverted fashion, medial to the uterine artery, directly approaching the transcervical ligament. Now we will keep on holding the holding ligaments at the level of transcervical ligament, and we will do anterior as well as posterior colpotomy. And then we will extend our colpotomy in CN on either side parallel to this holding clamps on both sides, such that we can remove the uterus and the cervix together as a single unit. After that, we will use our suture to secure the transcervical ligament and continue that suture onto the vault and thence onto the other side of the transcervical ligament, such that the entire supportive pedicles and the vault, they are treated with a single suture in a single fashion, so that we secure the vault closure as well as vault support in one single step. This is the apical view of the surgical technique. We can see that the holding clamps are placed medial, and then we directly ligate the pedicles together. The first two pedicles on both sides are ligated together, and then 1 centimeter margin is left for safety, and we will transect after leaving safe margin on either side. So this is a pictorial depiction of how a traditional hysterectomy gives look to the vault at the end of the surgery. This is the vault when we have not taken the supportive sutures on either side with the transcervical ligament. The vault totally stands out independent of the transcervical pedicles on both sides. And we have to take additional suture to secure the pedicle with the supporting ligaments in the traditional hysterectomy. So this is picture taken from live surgery. This surgery was done in the traditional fashion, and you can see this is how the vault looks at the end of a traditional hysterectomy, unless and until we take the vault supportive sutures with this vault. And this is how the vault looks like at the end of hysterectomy being done through the Q-Rush technique. The supporting ligaments are directly tied during the vault closure in a Q-Rush technique, making this technique more efficient. So this is the result from our pilot study. This was done in the year 2024 from January to December, and total 15 cases were taken in both groups. And I would like to make a disclaimer that this study was originally submitted in the urogynecology benign surgery category and not in malignancy category. And these cases in both groups, the 15 cases in each group were also of benign nature. And they were comparable biologically. In terms of BMI, age, parity, and non-surgical cases were taken, those who were never operated previously. The mean operative time we can see was shorter in Q-Rush by an average of 12 to 16 minutes. And other variables in terms of blood loss, hospital stay, vesicovaginal fistula, bladder injury were comparable. However, there was one case of post-hysterectomy vault prolapse in traditional approach, and none of the cases with Q-Rush technique reported with post-hysterectomy vault prolapse. Although the number is small, yet it is statistically significant, and this shows us that we need further studies to confirm the authenticity and validity and further usability of the Q-Rush technique. So I'll conclude my presentation with a remark that innovation in the surgery is often imagined as robotics, artificial intelligence, or advanced technology. But sometimes innovation is much simpler. Sometimes it is just looking at a familiar surgery with fresh eyes and fresh mind and revising its steps. Q-Rush is an attempt to make open hysterectomy faster, simpler, and anatomically smarter. And if it reduces the operative time, improves apical support, makes surgery easier for the next generation of surgeon, I believe that our spines and our physiotherapists will be both extremely grateful for this surgery. Thank you so much for your listening.
Thank you, Dr. Kutsia. Now we'd like to request the expert panelists to kindly conclude the session.
Thank you very much, IRC and the team of Shalimar Hospital and Nazli and everyone for giving us this opportunity to listen to these innovative techniques and research from Pakistan, original research from Pakistan, which is very, very encouraging. And I must congratulate all the investigators and the presenters, starting from Nadia from AKU to our last speaker, Dr. Qudsiya Nawaz. And हमें सारों ने कुछ ना कुछ झंझोड़ दिया है. And I'm quite happy to listen to all of them. I think I'll just give one or two comments. The first speaker, Nadia, ने हमें बताया कि उसमें हमें RRSO ज़रूर करना चाहिए for this BRCA positive breast cancer patients. So unfortunately, हमारे यहाँ gynecologist, we don't practice this breast surgery. So I think it can be combined with mastectomy, can be combined with bilateral salpingo-oophorectomy in the high risk and positive BRCA1 and 2 positive patients. And it is highly recommended because of the higher incidence of 52 to 80%. So I think we should take note of this. But the unfortunate thing is that I